We are starting with today's session now. Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet is India's most trusted and widely used digital platform, offering a multitude of enriching services exclusively for the doctors. Clarinet is slated to be chosen as the digital partner for this event organized by Association of Madhya Pradesh Obstetrics and Gynecological Societies. So today's focus would be International Caesarean Awareness Month theme Informed Consent, Empowering Birth. Let's begin today's session. For I would like to invite Dr. Anjum ma'am to take over. Over to you, ma'am.
Thank you, Swastika. Good evening, everyone, and a very warm welcome to all our esteemed guest faculties and all the delegates who have joined us for this webinar on International Caesarean Section Awareness Month. It's jointly organized by the Association of Medical Women in India and Association of Madhya Pradesh Obstetrics and Gynecological Societies. This month reminds us of the importance of safe, informed, and respectful childbirth. Thank you all for joining us as we come together to raise awareness and share knowledge. We look forward to have a full session. So let us begin by invoking the blessings of God. Clarinet, can you play the lighting of the video?
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Thank you, Swastika. Thank you, Swastika. May I now request Dr. Rupali Dharwadkar to introduce President of AMWI, Dr. Mandakini Megh, ma'am, and President of AMPOGS, Dr. Anjali Kanhere, ma'am. Dr. Rupali Dharwadkar is an obstetrician, consultant obstetrician and gynecologist at Surya Hospital, Mumbai, having a MS MRCOG degrees and number of awards to her credit. Over to you, Rupali.
Hi, everybody. Good evening. A very warm welcome to all the faculty members. We're very, very happy to see all of you here today. This is an amazing webinar which we are having, and the organizers are Dr. Mandakini Megh, ma'am, and Dr. Anjali Kanhere. We welcome you all. We would like to have Dr. Mandakini ma'am's CV, please. Yes. Ma'am doesn't need an introduction. We all know she's an awesome and absolutely great person at heart. We meet in conferences, and it is an amazing feeling to meet her. Ma'am is a national president of the Association of Medical Women in India, Central Council. She's a chairperson of the ICOG FOXI 2020-21, and she's international vice president of Central Asia. She has many awards to her credit. Most important are the Sarita Bhalerao Award, the Gauri Puraskar of Government of Maharashtra in 1990.
It's okay.
मैडम अच्छा लगता है, बहुत सारा है पढ़ने के लिए.
थोड़ा पढ़ो कोई बात नहीं.
She's also got Dr. Ganatra Awards, MOGS for Community Services in OBGY, the Mahila Gaurav Puraskar of Government of Maharashtra 1996. Ma'am, we would like you to have a few words.
Okay. Can you stop this video? Stop sharing, please. Stop sharing, yeah. So, good evening, everyone, and I'm extremely pleased to welcome you all with our very favorite people of MP from Bhopal, Anjali Kanhere, then from Rewadi, our Dr. I just forgot. Huh? Mitra Saxena, Kirti Donde, Anjum, and my own, our own city stalwart, Dr. Ajit Virkud, and my joint secretary, Dr. Gauri. I think it is a very nice thought of Archana Basir. It's because we are having this international awareness of the Caesarean month, it is better to have all the obstetricians together from different states. So, Archana, thank you for that thought. And now we are having the implementation. So, most importantly, regarding everybody is going to, all experts are there, so I will not talk much about it. But as far as the government is concerned, I remember 3-4 years back, Ajit Virkud and all of you from Maharashtra and from India will see that there was a question in the Foxy, ki how many cesarean sections are done, and they wanted a data. So we did a lot of research, myself, Jaideep Tang, and we were trying to defend our doctors ki why it is going wrong. And government is coming that it was 15%, from 15% to 40%, 50%, and the Andhra and other states, they are having almost 60 to 70%. So everything was boiling down on the obstetrician, and they were trying to reason it that they are doing the correct thing. But there was some doubt. So our government of Maharashtra started monitoring the cesarean sections in the private hospital and even the government hospital also. So that is the awareness. Government already had the awareness. So it is this, and also the safety of the labor. Now, other day, some obstetrician was mentioning, "Arey, madam, mujhe jana hai." But there is a this Pandit ji has given the timing of the cesarean section. So we have to follow not only the indications, not only the emergencies which are there doing the cesarean section, also the the auspiciousness and religious thing, and so many things are coming to and fro. So with this, I think today everybody is going to talk. AMWI actually is, very much with the women's health, and I will like to put up a few of, if you allow me to. I have 3-4 minutes. I have because
Yes.
see, I cannot go without. Can I share?
Yes, ma'am, you can share, ma'am.
Yes, ma'am.
Because what has happened, I just want to show you the. No, I can't share. Okay, I can share. Yeah. So I can share here. I can just give you the this thing. Huh. So this is today's web. Hurry, what happened? What happened?
Ma'am, you can try sharing it once again, ma'am.
Able to see the
क्या हुआ क्या हुआ इतना अच्छा लगा नहीं I don't know I did क्या हुआ
Swastika, can you just look
yeah, because this is very important which I want to talk in the beginning and set the ball rolling.
Yes, ma'am.
Yeah, just a minute. इसमें black ही आ रहा है.
Ma'am, you can do one thing. What are you seeing on the screen, ma'am? Are you able to see us?
No.
You can click on that escape button from the keyboard.
Okay.
And has the PPT got shut down?
No, PPT is in the background, no?
Okay, that black screen which you are having, is there is any kinds of options coming in there? Black screen.
I will try one more time. Otherwise, I'll just later on we can have because I don't want to stop the program now.
Yes,
So,
ma'am. It's visible. It's visible,
yeah,
ma'am.
so association of this MP Anjali Kanhere and myself as a MWA chairperson. So we are having this very important seminar which I already talked about, International Cesarean Day. And I just want to tell you, all of you, that our organization, Association Medical Women, many members are there here. Archana has recently become, we are 120 years old organization, women doctors. And we were the first to open this medical college, Grant Medical College part, that is a common Elbless hospital. And you can see here the centenary celebration. We celebrated 100 years when I was the Mumbai president. So this is very important. Some of the slides I want to show you because all of you are new to the Association Medical Women of India. You can see the Governor Sri Krishna Honorable Krishna sir, and this is Dr. Usha Saraya Mundala madam. She was a health minister, principal secretary, myself. So this was a wonderful program where women doctors were having the program in the Raj Bhavan, where the cabinet minister takes the oath. So we have a very glorious past, and I think we should carry forward that, the legacy which has been created by our this thing. And I take it on me and all our women doctors and even men doctors also, that this women's health, so much we are into the women's health and carrying forward all the government agenda. So this is Kama and Helpless Hospital where it was established, and you can see the our national executives. I'm the national president of India also, and I am the after there were five presidents who were British presidents. They were all British women, and now I am the 22nd president of India. These are the doctors which were sent by Queen Victoria to start the Kama Hospital for the women, because at time PPH, sepsis, all those things are rampant, and she couldn't see it. And there were no women doctors, there were no education for the women, and that is how they were sent. And our organization AMWI was established in 1907. You can imagine now we are already 120-year-old. So these are the few of the very nice coincidence is that first AMWI president, Dr. Dadabhai, what is her name? Dr. Dadabhai, she was also the president of Foxy. That is a coincidence because she, helped the Foxy to, as a organization, because she was AMWI president also. So this was a different fund. You can see so many, I think, Ratlam and so many other places, there are women hospital. Delhi, Lady Harding was also established by. So Queen Victoria, there was a royal help from the England, and all these ladies, the ladies which were so much devoted, so much devoted to the women's health. That Dr. Girard, the Dadabhai, Dosi Bhai, I just mentioned. So all this. So what I want to tell you, all of you, that we have a very great legacy of women doctors who brought the women organization. Women doctors, that time hardly they were, hiding in the nurses dress, and they were not being given education. Anandibai Joshi was the first example who just went. But later on now you can see almost 60 to 70% are now the women and girls are there in the medical education. So we are very indebted to Queen Victoria also for sending. This is our lovely structure. You all visit our Kama hospital. Here the cytology clinic, AMWI is having the office, and we have this cytology clinic. And just I wanted to show you, this was my office, Kama Hospital Superintendent. I was very fortunate to head this office for a long time. This is the organizing committee. You can see who's who here, everybody in the India. You can see here, I am leading the organization that time also. These are our aims and objectives. And as a AMWI, we are committed to the women's health. We are committed to the whatever agenda government gives us. We are doing so many international workshop of domestic violence training we are doing for the doctors. Dr. Gauri is also one of the conveners. And I was installed as a world president. It was a great pleasure for me to give you the information that I was installed as a first woman doctor from India in 120 years to become the world president of this organization, Medical Women International. So these are few of the beautiful pictures. India got many awards, many awards. We received so many 5 awards because of the work of AMWI, and we were very much appreciated at the Cairo conference, where 83 countries delegates were there. So, and we are having the global podcast. Gauri is doing great work. We had Leslie Regan very recently, and wonderful. I think you all should join and then we are having this 4-point agenda: menstrual health, non-communicable diseases, mental health, and violence against women. So you please be a member, be associated, and go to the national level and the world level. So with this, I think I will just stop my presentation and my information regarding so thank you very much. And I think once again, I'd like to welcome all of you and all the doctors to become the member of this very prestigious organization. And now floor is open. And I hand over again to Dr. Anjum and Dr. Gauri. Thank you very much.
Thank you so much, ma'am, for your valuable insights. Can I request Dr. Rupali to welcome AMPOGS President Dr. Anjali Kanhere, ma'am?
Yes, can I please have Madam CV? Yes, we welcome you, Dr. Anjali Kanhere, ma'am. Ma'am is she's a president of the Madhya Pradesh Obstetrics and Gynecology Society. She's a former fellow of the GS Medical College, Mumbai, professor and the head of department of ONG CMCH Bhopal. Madam is also the president-elect Association of MP OBGY Societies from May 26 and 28. Past president of the Bhopal Obstetric Gynec Society. Madam has many awards to her credit, and she has also the moment of appreciation from the AICOG 2025.
Dr. Rupali, if you can just cut that short, please.
She has many awards, and ma'am, we would like to hear 2 words from you.
Thank you so much, Mandakini madam, for inviting me on this platform, and Archana Baser madam.
Stop sharing, so that we can see each other. Yeah.
Yes, I'm going to take over Association of Obstetrics and Gynecology Society in Madhya Pradesh from May 26. And definitely we are going to be working hard. Our previous team has really done wonders, and I'm planning and we are hoping that we will be able to take their work ahead for our Madhya Pradesh patients or women health. It was wonderful to know Mandakini Megh madam's work. I have been associated with her for a very long time, and it's always a pleasure to meet her. And she भले ही मैडम रहती मुंबई में है, लेकिन उनका दिल इंदौर में और भोपाल में बसता है, ये मुझे मालूम है. So thank you so much, Megh madam. And yes, we are looking forward to have our national president in form of Dr. Archana Baser. So a sincere request for you all to be a part of this election to make Madhya Pradesh come strong on Central Forum, and we'll be very happy to work with Baser madam to take Madhya Pradesh to higher heights. Again, thanking you for selecting such a wonderful topic, because almost every patient is aware about cesarean section now, whether she has undergone herself, some or the other relative has had cesarean section, and this is something which is evolving every day with another type of complications. And I'm so thankful to madam to take this topic, and to have Dr. Ajit Virkud, none other than a teacher of teachers, to talk about complications and so many things for this webinar. Thank you once again for making me a part of it. Thank you, and I wish all the best to Mandakini madam to be the world president. And we are looking forward to have Dr. Baser madam as our Foxy president. Thank you so much.
Thank you, Dr. Anjali. Thank you. Your word means a lot, because it's coming from a MP chapter president. I think that's a really very, very grateful to you.
Thank you so much.
Thank you so much, Anjali ma'am. Mandakini ma'am, can we go ahead with the scientific session?
Yeah, please, because Bhaskar and they will join in between. They are in the meeting, na?
Yes,
so let us, because we should not delay. We should not delay, yeah.
So we are honored to have our esteemed chairpersons for the talks today. It's my privilege to introduce the first chairpersons for the first talk, Dr. Sumitra Yadav ma'am and Dr. Padma Shukla ma'am. Dr. Sumitra Yadav ma'am is professor and head of obstetrics and gynec at AMWI, Indore. She is the president of Indore Obs and Gynae Society, and madam has a number of awards to her credit. And also, she has been bestowed with the prestigious Ahilyabai Award from Free Press Journal. And I would like to request, to have the CV of Padma Shukla ma'am now. Padma Shukla ma'am is the president of Reva Obstetrics and Gynec Society. She was also the organizing chairperson of AMPOGS 2025 Reva. Madam has a number of awards to her credit, including CS Dawn Prize and DC Datta Prize. She has special interest in vaginal surgery and high-risk pregnancy with more than 15 publications in National Journal. Welcome you, ma'am. Can I request Sumitra Yadav ma'am to introduce our first speaker, Dr. Archana Baser ma'am?
I think Sumitra may not be here.
She had told.
At managing committee, why don't you just introduce in short? Because
May
I've already
I
been
request Padma
introduced. Yes.
to introduce you, ma'am?
Or is Padma there?
I think Madam was here.
Yeah, Padma can introduce me. Yeah, she's here.
Sure, ma'am.
It is my pleasure to introduce Archana Madam, Archana Basir Madam. Madam is a well-known person, and Madam was chairperson and vice president in 2020, chairperson MP SR in 25-27. Madam has fellow represented has represented in AICC, RCOG, West Zone, and joint secretary is PAR 25 to 27, organizing secretary in AICOG 2021 Indore, which we have all seen. It was very organized very well by ma'am, and madam had got the past position chairperson Foxy Imaging Sciences Committee 2015 to 2017, organizing secretary ISAR in 2016, and managing committee, madam was managing committee member in so many committees, and madam has, sorry, actually I have joined with the phone, ma'am.
Don't worry. I think it's enough, Padma. I
Yeah,
think everybody knows me on this platform. So
very well.
I think you should go ahead because we have
yeah,
been
thank
waiting
you
for
so much.
time.
So
Ma'am.
with the due permission of the chairpersons, can I start my presentation, and may I be allowed to share my screen, please? Is my screen visible?
Yes, ma'am.
Yeah, a very good evening to all of you. And I'm really happy that Mandakini madam has initiated this, that we should have collaboration, and you involved the all MP societies. And I was very happy that all from the MP societies, Anjali Kanhare, Sumitra, Archana, Kirti, and Padma, and all of them have really at one phone call joined. And I'm really happy to share the dais with my, very senior and very, very well known speakers who are like stalwarts in their subject. Dr. Mitra Saxena, I think she, whenever she stands, and she steals the show when it comes to cesarean section. And we have Dr. Virkud, my teacher, and my he was the honorary when I was at Bandra Bhaba. My dear friend Gauri, and Gauri is like a younger sister to me because we have been knowing each other for very many years. So I warmly welcome to all of you on this platform, which is being created by Dr. Mandakini Megh for us, and we are holding it at the MP. I'm sorry that I am checking the first difficult situation in cesarean section ahead of you all, because I just had to move to the airport, and I'm just going to talk on difficult situations in cesarean section. We all know that cesarean section is becoming very popular, very common, as already told by madam and our guest of honors, that cesarean section, women are aware of cesarean section, and so are the doctor, and it is important, it's our duty to see that whatever is the mode of delivery, whether it is vaginal or whether it is C-section, it is safely done. So why we still talk about C-section, though it has been practiced for hundreds of years, because it is one of the most common surgeries performed, and thousands of practitioners in India alone are doing C-section, and most material says evolution of C-section is by trial and error. Now the problems in C-section can come in many shapes and sizes. You can have expected difficulties like what Saxena is going to talk about, the placenta creta syndrome. You can have unexpected complications. There are certain times where you have to make choices in the operation theater. There is now the newer challenge which we are facing is a social obstetrics, and sometimes things just go wrong howsoever prepared you are. So I just have 5 cases which I'm going to quickly run through and let you know each one. So expected difficulties. This is my first case. This was a patient who conceived with IVF, obese, comorbidities. She has hypertension, diabetes, previous scars. I only did her one myomectomy, and she had a myomectomy done before as well. Somewhere else, she had a malpresentation, multiple gestation, placenta previa, oligohydramnios, preterm, and still she had fibroids and all problems in one. So when you have an expected difficulty, what you do is you can do a planning ahead. And she had a twin pregnancy. So what we do whenever you're planning ahead with all these problems, so you're anticipating problem, anesthetic problem, obstetric problem, pediatric problem, and recovery staff problem. So do a briefing. You do a briefing in the pre-op period only, or when you are booking her for C-section, do a briefing and connect it with the anesthetics beforehand only. And you should talk to the pediatrician. What we do in our practice, we have a joint meeting with anesthetists, pediatrician, and we warn the recovery staff that this is the patient who is like little overweight and these are the problem expected. So everything is kept ready, and then you take the patient. So these are the preparation for the big day. Like protocol, what you should have all blood biochemistry, 2 units of blood, cross match, physician, anesthetist, fitness, ultrasonography, NOT because it is a twin, and then sometimes before you take it, you have scanned her 2 or 3 days back, and when you are taking in OT, the position might change. And patient with so much of obesity, it is difficult. So it is very important to have ultrasonography machine in the operation theater, especially in the high risk patients, and counsel the patient, explain the risk, take a written consent. And what I normally do is 2 senior anesthetists, 2 pediatricians, and I had 4 assistants because I had a really, liberty and access to those 4 assistants and OT technicians, and create an action plan. Make sure that everyone was aware of their roles. Not otherwise, all 4 people are doing the same thing, so that doesn't help. So you have to say whose role is what. And the difficulties in entry, then there was a difficulty in opening the peritoneum, delivering, suturing, and high dependency unit into 24 hours. So this was the abdominal wall. What I do, when what people do, they they hold it with the valsellum and then put a gauze piece and retract the anti-abdominal wall. What I normally do, you do sterilize this strips and then just tightly put the strips and give one end to the anesthetist, and it really works well. You can try it, and then it is exposing the lower part of the abdomen and it is not hanging on mid. After a difficult case, we could do a perfect suturing. So that is all expected problem and sorted out very well. Patient went home well, and all her twin babies, both the twin girls were fine, and after 4 days they were discharged home. So that was expected. Now what happens when you have unexpected difficulties? This is Mrs. MK. She was my cousin's daughter, 27 years. She was a primary, conceived on subfertility treatment, uneventful antenatal period, spontaneous labor at term. She progressed very well till 9 centimeters, and she came on a Christmas day and with almost perfect condition for a vaginal birth. You would say plumb normal, she'll deliver soon. Now what happens next? She had no descent for 1.5 years. Oxytocin is on flow, no place for rotation, deep transverse arrest, and there was a fetal bradycardia, and there was a meconium down. This is a plan B. So the plan B is do a C-section. So how we manage the situation? It was an impacted head, most common unexpected problem. Peritoneum incision has to be given up higher up to avoid the bladder, gentle pressure to widen the incision, shoulder at incision, and was a thick meconium. Assistant at bottom and gently push the head towards the incision side. Mind it, I have put it in a bold not to push head before the uterine incision. Otherwise, you will push the bladder up and that will be a problem. There's a more chances of damaging the bladder. So after uterine incision, push the head. And other techniques also, you can do the Patwardhan techniques and other techniques to deliver. And final challenge is to suture the uterus. What happens in this case is that when you are suturing, there will be, because patient has a echymosed lower segment, it is going to get torn repeatedly. So you have to be very gentle in suturing. When you are suturing, tell your assistant not to pull your vicryl or whatever material you are using too harsh. Just be gentle and take the sutures close by, not very far away, so that there is a good hemostasis is achieved. And we have to be very, very meticulous in suturing this. And now let's move on to the case 3, that is choice in OT. This is Mrs. AK, 36-year-old, gravida 5, para 0, recurrent first missed trimester, missed abortion, again infertility conception, presented at 26 weeks with leaking. What we did, when a patient comes at 26 weeks with leaking, we gave her betnesol, good neonatal unit, good NICU, tried to hold on because she was not having any chorioamnionitis, no pyrexia, and cardiac activity of the baby was going on good. So pregnancy was continued till 29 weeks. We gave steroids and prognosis was guarded. Now, what difficulties we faced, because of first was the counseling and high risk consent was taken. She is a primary, she had no living child, 26 weeks. You do a counseling because if there is a you might have to do the hysterectomy. It's kind of a hysterotomy only you are doing. So high risk consent was taken. There was no lower segment, so we used the small forceps, and either you can use the low vertical incision, and you have to make choice in OT. A small forceps designed by Dr. Piley. I hope there is a picture, or maybe I'll show it sometime. It's just like a spoon, because our hands, if you try to pull a baby of 26 weeks or 29 weeks with your hands and are bigger, so use that forceps as a vectis, and that will really help very gently deliver the baby. Or sometimes you have to take low vertical incision and you have to make choices. Now the choice what I had to make in OT was a very difficult choice. Do a cesarean hysterectomy or leave the placenta inside, because the placenta for 3 weeks of continuous leaking and the placenta was stuck. I could not deliver the placenta. So there were two choices, either do a cesarean hysterectomy or leave the placenta inside. In between, one of my associate went out and asked, like, this is the problem. They said, let madam decide what is she wants to do. I left the placenta inside. And then we followed her up, gave her some methotrexate, and this was the patient was compliant. That's why we could leave it, and we had a good outcome. And this woman brought her baby recently, and she is now 8 years old. So what I meant by choices in the OT is you're dealing with a patient hopes and dreams. Choices have to be made quickly and with medical and experiential justification. Patient and relatives have to be briefed, and expectations have to be managed, and effects of choice have to be monitored till the patient is out of danger, because you have taken decision for the patient, taking her into or her relatives in confidence, but the onus is on us, and we have to really monitor it till the patient is out of danger. Now this is the case for social difficulties. She is 34-year-old, again a very heavyweight. Height was also good, 5 feet 7 inch, one normal delivery, but which was 9 years back, moderate preeclampsia, and she had 37 weeks ultrasonography, polyhydramnios, and unstable lie, and estimated baby weight was 3.8 kg. She came with leaking and pains at 38 weeks and was oblique lie. Head is in LIF, back anterior, no Liker pocket, CTG was suboptimal, and it was difficulty started from obtaining the consent, because this patient was not at all giving the consent. I had first vaginal birth. Why you are doing a cesarean section for me? I was speaking, but still, I could convince her. Took a phenestrel incision, and I had adrenaline rush in OT. I delivered, because it was an oblique lie. I delivered the hand first and reposited back. I had no backup plans actually, because I thought it will be, we do a section oblique lie, we'll just either with the breech or just put a forceps and we'll deliver. But we delivered the hand and head. So what we did, we took the head up of the mother to reach the fundus, because she was a tall woman with a heavy weight. Sometimes obstetricians height you could not reach it, but we did the head up, gave some relaxant, and uterus was so tight on baby because of the leaking, and I had to make a J-shaped incision, ask the anesthetist to give relaxant, and delivered the baby by breech. But again, the patient later on developed the ileus. So my problem didn't finish after delivering the baby, and we had to handle that ileus for 4-5 days. So the take-home point from this case is the key to avoid problems and obstetricians palpitation and planning. One must know when to expect troubles, plan anesthesia, abdominal entry, uterine incision, and method of baby delivery, keeping all the factors in mind. An adequate knowledge of fetal lie, presentation, station, degree of flexion, position of occiput, and placental localization helps to plan the method of delivery. And to reduce the adverse neonatal outcome, induction delivery interval of more than 8 minutes and incision delivery interval of more than 3 minutes should be avoided. And this is the last case of my presentation, and this is once in a lifetime case, which I am sure I'm not going to see in my lifetime. And I don't know if anyone of you have had this kind of a case. So I would end with this case. This is Mrs. GM, 30 years, weight 70 kg. She was gravida 8, para 3, 4 abortions. Previous 1 C-section, alive and well, and 2 intrauterine death at 36 weeks. That's why she went for this pregnancy. Now, she is diagnosed with duplication of Mullerian system, but we know that she had a singleton pregnancy in the left horn. She presented at 32 weeks with preeclampsia, transverse lie, confirmed on ultrasonography. I was planning a C-section at 35 weeks, looking at all her history and preeclampsia. However, at 34 weeks, she presented with severe hypertension and decreased fetal movement and had to perform emergency C-section at 6:30 p.m. in the evening, I precisely remember. When I gave an abdominal incision, the fallopian tube and the large vessels were at my incision site. I really had no clue what I'm doing. I said, well, today though I'm in a very, very great difficulty. I thought it was just an oblique lie. I'll make an incision and deliver the baby. Now what happened? We did an oblique incision and deliver the baby. Now, when I delivered the uterus, just to see, that's a routine practice sometimes, like not every case we deliver the uterus out, but it was an interesting case where double uterus was known that she had a duplication. So I delivered the uterus, and when I'm delivering the uterus, you see here, there is no incision and no suture at all. So my head started spinning like, what exactly we did? Where did we deliver the baby from? So what was actually happening in this case, pregnancy was in this horn, the pregnancy was in the left horn, and because what we always thought was it an oblique lie, there was a torsion of the uterus. So this uterus in the early pregnancy had a torsion because of the good amount of peritoneum around. So torsion in the uterus was back to front, and when I made my incision, I delivered the baby from the back of the uterus. My incision was on the posterior uterine wall. So this is what exactly happened. Torsion of the gravid uterus. This was the right uterus, and this uterus was torsion. This is the left uterus, which was torsion. And then when we delivered it to see, we had a really surprise that where did we do the incision? So that was a torsion of a uterus, gravid uterus, which are being reported in the literature, but I haven't found very many cases. Lesson learned are very common. Proper preparation, experienced team, correct technique, right indication for C-section is very, very important. Manage the expectation of the patient, follow the protocol, stay calm. The most important thing is stay calm, take your time, proceed deliberately and carefully. Even if it is a tough situation, your experience, you will come out of it, but it has to be really stay calm. Don't panic in the OT. It should be the lesson, which is the most important lesson we should learn. And this is a small video, like how we use the forceps in C-section. I am sure like many of us are using the one-tuse, but this is just a simple, just put the forceps and this you apply the forceps and deliver the baby with the forceps. It doesn't require, so that I think that most of the obstetricians, this knuckle and the joints get problem in the later life because you have been, somebody is giving fundal pressure and your fingers, knuckles get compressed by that. So it is important that we do not do that much of maneuvers with our hands, just do with the forceps. So take home points, here is the key to avoid problems and I think we have already done with this. So just guidelines are to anticipate potential difficulties. There is paucity of literature on difficult deliveries of C-section. Only case studies, expert opinion, or small case series are available. So what I want to end with there are always contrasting situations in life, as well as in the surgery, as well as in the obstetric practice. So be prepared for a storm and for rain on a sunny day, dear. So thank you very much for patience listening. I invite you all to our conference in Indore on 8th, 9th, and 10th May. It is all Vice President conference, and I am contesting for Foxy presidential election this year, and I would like your support and would ask for your vote. And I will be with you. I'm for you. I'm by your side, and I'm one of you. So thank you very much. And I will stop sharing here.
Ma'am, thank you so much. Wonderful selection of cases. Many common and some very rare we all encounter as obstetricians. Kind comments from the faculty and chairpersons.
I think, Archana, you have demonstrated it beautifully. And your this message is very good because all the time we are pushing our hands, all the time. And instead of pushing, using our hands and knuckles, really we have to use the vectis or this thing. This I agree because I remember in our days, we used to have 6 to 8 cesarean section per day per surgeon. It was a 11,000 to 12,000 load. You must be knowing this. And it was, I mean, really a very practical thing. Moreover, what is very important is your assistant also should be very, I mean, skilled to, help you in, performing your difficult C-sections. And so many times I think we have used to give the, sir will agree with me, sometimes the tea we used to give when there is some scarring or something like that. Some tea incision because it was so difficult to take out the, head. So
T incision, J incision, we were used to do. Now the techniques are also evolved, and so many things have come, like good suture materials. In olden days when we were operating, sometimes cautery were also not available. But I think things are really getting better. But still, what we need, as you said, is important. That planning. I think planning ahead is very important, and the right indication.
thank you very much for that lovely talk, I think. And Anjum, you can go ahead. Kirti wants to say something. You are muted. You are muted. You are muted. Muted.
Yeah, ma'am. Nice. Cases madam has shown, and it was really amazing to see that you have managed so difficult cases. Madam, we have also seen one case of torsion uterus, and it was similar that we find out suddenly that where is the suture line. So then we got to know that it is on the posterior side of the uterus. So it was really excellent presentation, ma'am. As usual, as you always do. Thank you, ma'am, for nice presentation. Thank you so much.
Madam, I just wanted to ask the second case of yours where you left placenta which was adherent. Then what was the prognosis of that patient? After.
Yeah, I think it's very important. Yeah, important question. And I think I was expecting that someone will think of it and someone is going to ask me this question. What happens, Kirti, when you are leaving the placenta? Either you do a hysterectomy, right? Which is a hysterectomy, sorry, which you don't want to do in a primary because you are scared that this 26 weeks baby or 28 weeks baby may not survive. And you are doing a hysterectomy, so you are leaving her with no reproductive life further. So in the placenta, what I assessed was that this placenta was not bleeding. So I think I was very lucky that this placenta when I left was not bleeding, and I closed the abdomen after talking to them, and we gave the methotrexate, and we were following her up. This was like first time I left the placenta inside. I was every day, measure with the inch tape, the girth, it is not increasing, patient is not bleeding, like everything was on high alert. We had like monitor the pulse, we kept the patient in HDU, all the staff was very, very alert. And once the 48 hours were over, we knew that it's not now going to bleed. But I was very lucky that patient was compliant. I called her after 7 days, did a scan, that there is no bleed and there is no there is no inside, there is no pyrexia or infection happening. So you got to be lucky when you take some tough decision. You have to
I think
We
Madam,
don't
the
mind listening
the
to you.
findings in the scan, you must be having the calcified.
Question can be asked on it because senior faculties are waiting, so
Yeah.
we have to look for the time also.
Thank you, madam. Thank you.
Yeah. So Mitra, it's your second talk.
Yeah,
Sorry.
Yeah.
First.
may I
Yeah,
request
ma'am,
Dr.
Mitra ma'am,
Padma
thank you so
Shukla,
much for joining in.
Yeah. I wanted to ask Virkud sir whether he want to. Sir, तुम्हाला पहिले बोलायचं आहे का?
नहीं hello,
Okay,
yeah,
okay.
no, you can go ahead with the talk. I'll talk later, no problem.
Thank you, sir. Can I request Padma Shukla ma'am to, I think she has just left. Can I request Kirti Donde ma'am to introduce our next speaker, Mitra Saxena ma'am?
Sure. It's hello everyone. This is I'm at the outset, I would like to thank respected Mandakini Megh madam and Dr. Archana Baser for inviting me for such a meeting. And it's my proud privilege to introduce Dr. Mitra Saxena. She's Vice President, VP elect Foxy 2027. Ma'am, she has got so many. She was Vice President Foxy Elect 27 and Governing Council member ICOG 2026-27. And
Dr.
she has
Kirti,
organized.
Dr. Kirti, please don't mind because the talk time gets decreased and it's okay.
Thank you, madam.
We all know each other, and I think the audience time is very important.
Thank you.
So
Yes.
allow me
Go
to
ahead, go
share.
ahead.
I'm so sorry. I
No,
just don't want that
That's
all after such a wonderful lecture. It's just 1 second here. Swastika, please give me the rights to share.
Yes, ma'am, you can now share it, ma'am.
No, I'm not able to see my own. Yeah, wait 1 second.
Started screen sharing now.
You'll have to tell me. Can you see the? Can you see my screen?
Yes.
Yeah.
Yes, it's there.
Okay, so somebody be the timekeeper so that we don't step out. And I just want to make 2 comments before I go on to my topic. So first, I want to say best of luck to, of course, thank you to Dr. Mandakini Megh. आप हमारे दिल के बहुत करीब हैं. Thank you for always being with me. Some other day, I will tell my journey with her. Anyhow, and then thank you, Dr. Archana, for thinking of me to be included in such an important topic. And I'm very sorry that I'm not there with you in May, in person. This is the topic I would have chosen for myself. So I thought, okay, let me do it digitally. And for the audience and for all my friends, it's a very big honor for me to go before Dr. Ajit Virkud. Just let me tell you, as chairperson of Practical Obstetrics Committee, I was really hell-bent that every obstetrician should be skilled in learning internal iliac artery ligation. And that is the time when I looked up all the available YouTube, all the teaching methods of Dr. Ajit Virkud. And it's a really good, opportunity for me to, be with him on the same platform. Today, what I am going to be talking about is what's new in PAS, placenta accreta spectrum. So, well, friends, all of us know that this spectrum, it's a iatrogenic epidemic, which is an entity with a wide range of clinical presentations, from cases with mild lesions requiring moderate surgical efforts and associated with fewer complications. We have severe ones with a challenging management and life-threatening risk. Individualizing the management of PAS is extremely essential, especially when a significant percentage of women undergoing PAS surgery ultimately do not have this diagnosis or present superficial or focal lesion. What I want to say is that the scare for PAS is now become so big that we forget the logistics. The majority of patients are just accreta, or not even accreta, they are just dehiscence and placenta previa. But every case is taken with a very big diagnosis. So we overdo at times. And let's not forget that some women will wish to preserve their fertility, or that vascular interventions or the hysterectomy itself can cause additional morbidity. When I say that, you need high resources, you need invasive radiology department and all. So from high resource settings, we can now move on to lower resource settings with whatever information I'm going to be sharing with you. So, 2 decades we were not even aware. And over the last 2 decades, there has been a disaster plan. Okay, this is past. So let's either cannulate the vessels or ligate the vessels, do a hysterectomy. And then in hindsight, when we see the uterus, we find, oh, this could have been saved. So now, if you look at this image, I'm sure if this is the history given in the previous cesarean, and this is how the uterus looks, lower segment or opening, we have some questions to be answered. Should this be a surprise to test for any of us? Are we prepared to handle it? It's not that only tertiary centers will be able to do it. Can we, in the smaller places, with our teams well versed with everything what we can expect, can we manage these? And what are the surgical options for managing PAS? And can we prevent PAS if time allows? So, of course, let me go first. There is no doubt that ultrasound screening has to be done in every case who comes to us, especially those cases with previous cesarean section. Let us remember that a gestational sac within the scar niche is a baby pass, and that is the way you can avoid pass at the outset. If you see the sac in the niche, you can say this is a cesarean scar pregnancy. This has to be, taken out, and of course will not encounter pass. We can repair the niche and then patient will be followed up. But there are instances where the patient would want the pregnancy. So what to do? So we have to wait for the pregnancy to grow big and localize the placenta. And of course, it is more sense to refer patients to specialized centers. Yeah. But if we go about in the way, after having attended this workshop that we had with Dr. Jose and Dr. Albaro, and I'm happy to say Dr. Sumitra, Dr. Anjali, Dr. Padma, all were a part of our workshops, and I'm sure they will endorse all the teachings and recommendations, because practically a lot of them who have been dealing with PAS have followed these teaching protocols and come out with very good results. So the most important thing is in PAS, it has to be corroborated with the intra-op, post-op and histopathological finding to actually say that whether our choice of surgery and our mode was fine or not. Now, in ultrasound, I am not going to give you much. Only thing is that your ultrasoundologist should perform in 3 planes, sagittal, axial, and coronal. And more importantly, you can see that line diagram. So if a good sonologist does transabdominal and transvaginal scanning, you should be able to design, make a line diagram and have a 3D concept in your mind. I'm not going to go into the details of the findings of PAS on ultrasound, but remember that even if this was a placenta in the lower segment, if there are no lacunae, if it was a uniform, homogeneous presentation, then the chances that this is a normal placenta is very high. This too much, vascular spaces, they tell us that there is turbulent flow and that there will be placenta accreta. Now, these are the prescribed views, sagittal, up, down in the vertical direction. Then for axial view, right to left, and coronal, horizontal probe and above downwards. Similarly, with transvaginal, you go from right to left, you go from out to in, and you go horizontal right to left. Once you do all these things, you will be able to actually draw a picture of what is to be expected. There's a lot of debate whether MRI has to be done or this and that. Let me tell you that there are no clear-cut guidelines, and one has to understand that good ultrasound examination by grayscale and color Doppler, where it is important, only that is important. And what most important thing is that is there a clear hypoechoic zone behind the placenta and the uterine wall. So that is very, very important. And then this is kind of supplementary. This is not the reason how and why we should be referring, and we should not be afraid of every case. Now, what's new? These are the 3 topics I will be taking. I'll try to cover them. Although this is a very, very big, the whole thing, we took 2 days, but today I have to, make a summary and present it in the next 15 to 20 minutes. So first important thing to understand is the vascular anatomy so that we can manage the vascular pedicles. The second point, which is very important, is the topography for the lesion location, so that we know every part of the uterus has different arterial supply and poses different surgical difficulty. Lastly, what are the options when we are confronted with PAS? Either we can do conservative surgery, or we can do total hysterectomy, or we can do modified subtotal hysterectomy. So on the surface, it's actually, basically speaking, very, very clear and clean. If we know our anatomical, vascular anatomy very well, we'll be able to do almost anything and everything. Now these are some very new diagrams which have been incorporated in the recent papers by Dr. Jose, who's an anatomist. So we are all aware that the upper segment is supplied by the uterine artery and the ovarian artery, 80% by the uterine, 20% by the ovarian. So upper segment bleed will be taken care of by ligating these vessels or doing a upper segment compression suture, B Lynch, etc. Now coming to the lower segment, we have to understand that the concepts have changed. It's not that there is a descending uterine or cervical branch. It's that the colpouterine arteries, three, right and left and azygos in the middle, they derive blood supply from the lower vaginal or the internopudendal vessels. And here there is a very rich anastomosis in the lower segment. So basically, what is most important to remember is the landmark of the site where the peritoneum is loose over the uterus. So upper part is where it is tightly adherent to the uterus, and the demarcating line is from the line where the bladder reflection. So utrovesical peritoneum that has the bladder. So this is the main area which poses problem whenever there is placentation here, whether with scar or without scar. So the placenta is here, it will be lower segment, placenta previa. If there is a previous cesarean, again it could be placenta previa or adherent placenta. But here, because the vascularity is very high, that is why it becomes a bloody affair. So now very clear these three segments, S1, S2 and S3. S1 I have already told you. S2 are the colpouterine vessels. And S3 segment is that which has the vaginal vessel. So whenever there are tears in the vagina, upper, lower, so pudendal vessels or vaginal arteries, they are the ones, they are the culprits. Now, these vessels have been, actually they have been there, but they have received their respect and recognition as late as in 2006. So when Dr. Jose has been studying this very, very sincerely, and doing dissections and putting, dyes and taking images, doing angiographies and discerning the presentation of these vessels. The important thing is this, that once they devised how to control these vessels, they were able to successfully remove the diseased part and save the uterus. So, they had a hypothesis. They have done surgery on the basis of that in a protocolized manner, and now they're able to reproduce it. So kind of validates that these concepts are not just somebody's imagination. They're very much there. They are doable. They are reproducible. Now, this is the very important diagram that I'm showing you, S2 segment, because this is what is our area of interest. This is the bladder, which is present in the lower segment. So this is the crux. Once this bladder can be, dissected away from the lower uterine segment, anything and everything is possible in any case, whatever may be the complication. Now, I will go into, yes, a word about, I was a very, very big champion because I thought that learning how to ligate internal iliac artery is going to settle a lot of our problems. But let me tell you that we are only ligating the anterior division. And anterior division, it's, if you are going to ligate the uterine artery, you're going to achieve the desired effect. Because the lower segment and the cervical region, which can bleed, they are not supplied only by the anterior division. They are getting their supply from the inferior vaginal, inferior vesical, internal pudendal, which can be branches from the posterior division. So here it has come to the, understanding that in case you need to do vascular pedicle control, better to temporarily occlude the common iliac or the aorta infrarenal. So we will come to that later. Now coming to the next point, and if the anatomy is clear, let's go on to the topographic classification of PAS. What is the meaning is that we consider the lesion in respect to the location, whether it is in the upper segment or it is in the lower segment, it is in the anterior wall or in the posterior wall, it is in the lateral wall, or where is it? So according to the location, we are going to have arterial supply and also the surgical difficulty. Anything in the upper segment is not a surgical challenge, but in the lower segment where the bladder is adherent, so you know that there is constraint of space, so it increases the surgical difficulty. Now, these topographies have been described into 5 levels. I will show you, but we will, it's very, actually, it looks a little busy, but it is very simple to understand that each area is supplied by some pedicle which can be identified, so that can be tackled, and then the decisions to do one, second, or the third procedure is possible. Now, most important thing is dissection of the retrovesical space and identification of the arterial pedicles. They are really, really important. Once you're able to, separate the bladder, you are going to be able to manage what you're supposed to do. So that is why the surgical classification is on table. This is something really very, very simple, but something totally new to all of us. We always thought that having a plan, you are always planning, we will open it in vertical, do a classical cesarean section, don't touch the placenta, take out the baby, close the uterus, and do a total hysterectomy. So you would tackle the bladder later. Now, in this surgical staging of PAS, things are a little bit, protocolized, and they have done numerous cases to back up their, steps that they have taught all of us. So, surgical staging involves opening the avascular spaces and evaluating the posterior uterine wall. Now, this slide looks very busy because it has all the 5 levels and all the vessels. But if you just remember, go over the first slide, which I showed you, S1, S2, S3, that's it. There's nothing extra. And basically only 3 options. Most of the time you can conserve this uterus if it is needed, or if the bladder can be dissected, you can always do the hysterectomy. But when the operability is poor, then you have to do modified subtotal hysterectomy. Now, as I said, these are all the diagrammatic representations. But when you are saying topographic classification, what is it that you mean? What uterine wall is affected? So here you can see which it is the upper segment. What can the bladder be dissected? That's the second question. Is it above or below the peritoneal reflection? What arterial pedicles are involved, and how difficult will the surgery be? So if we have the idea, we will know. We are going to, I'll just show you some diagrammatic representations. Now, I've already said this, that whether it is the upper or the lower segment, what pedicles will have to control, and whether it is anterior, lateral, or posterior wall. So we have to understand if it is lower part of the uterus and its lateral wall, that is going to be difficult because you have to go laterally. So you are going to find it technically difficult. Similarly, what is the most important thing about PAS? So we were very afraid that there is neovascularization. So, the vessels have invaded the bladder. Let's come back. Let's see what it is. Actually, it's not that the vessels from the placenta are going into the bladder. It's that the bladder is giving blood supply to the neighbor. Because the trophoblast is poor, placentation is poor, so it's deriving blood supply from the neighboring areas. So neovascularization is not something which cannot be tackled, because although they are fragile vessels, but there is a technique, and that is you independently lift every pedicle and you doubly ligate it and cut it, doubly ligate it and cut it, and you will be able to dissect the whole bladder. But what feature of PAS is very difficult is fibrosis. So this, if there is fibrosis, that means that it becomes inoperable. So between neovascularization and fibrosis, we have to understand, if we are dealing with fibrosis, stop. You will not be able to dissect the bladder. You have to have a plan B. Now, so as I said, that the role of staging of PAS intraoperatively is that one size does not fit all. Oh, oftentimes, if we go with our general plan, we may have done more than what was needed, and we may compromise the safety of the patient. And if we do too much of MRI, I recently had one patient, I was asked an opinion, and my friend said, MRI is reported that there is adherent placenta. I looked at the 2D, I said, no, it isn't. But they went ahead and they did a hysterectomy. The uterus could have been saved, and MRI was actually not, needed. Now, let's look at the images. I will actually show you. This is a very, very important slide. You can take a picture, because what happens is we have a general idea. Of course, I'm not going into the management, how to optimize the patient, what is the time of surgery. I think that is already everybody is quite conversant and all those things to be filled in. But what is important is topographic classification intraoperative. So the first important thing is, if you can dissect the bladder and you start from the lateral side, lateral wall evaluation, get the paravesical spaces open, retrovesical bypass, can you dissect the bladder away from the lower uterine segment and see whether there is fibrosis or there is neovascularization. Neovascularization, as I told you, that you can independently, you're supposed to doubly ligate the vessels and cut them. You'll be able to move the bladder totally. Now, these are the 5 types of PAS. Let's not look at them. Only thing I want you to look at this middle segment. Once you've dissected the bladder, you actually can basically, these questions have to be answered after we deliver the baby. So once we've dissected the bladder, we know we'll be able to do anything, but right now let's deliver the baby. So what is recommended is that you go above, you take a horizontal incision in the junction of upper and lower segment, means up above the placenta, and go through the placental wall and the uterine wall. And that's called Ward's maneuver, which you remember, we used to go by the side of the placenta. We should not go through the placenta, but separate it and then open and rupture the membranes and take out the baby. That's called Ward's maneuver. And once the baby is out, now we have already dissected the bladder. Now is the time to do the surgical or the topographic staging of the path. So what are we to ask these 3 questions? Is it possible to separate the bladder from the uterus? We could have left the dissection of the bladder halfway and removed the baby, delivered the baby, and then go and complete it, so that we can do it later if we want to save the time. Next is do we have 2 centimeters of healthy myometrium caudal to the pars area and above the cervix, and more than 50% of the uterine circumference is healthy? If the answer to all these 3 is yes, we can do total hysterectomy or we can do one-step conservative surgery. If the bladder is adherent, we cannot do this, we cannot do this, we have to go ahead and do the modified subtotal hysterectomy. So it is not difficult, but the idea only is that you will be able to know which will be the vessels you have to ligate and what will be the difficulty and how much bleeding can you expect. Now this is, I've already showed you the 3 questions to be fulfilled before we go ahead with one step. So after going from lateral aspect, dissecting the, opening the parametrium and dissecting the bladder from both sides, coming into the midline and Pelosi maneuver, you can separate the bladder. And if you have neovascularization, like the first image that I showed you, which looked actually inoperable, there all those vessels can be hitched, with this curved forceps and doubly ligated. So it's easier to tackle neovascularization, but we have to know how to do it. And after they are ligated, move the bladder away. After you remove the baby, you see the posterior aspect and then decide for one-step conservative surgery. So here what you're going to do is give the incision over here, transverse incision, deliver the baby, and then go ahead and take out this out in the bulk way. So this is the first step, parametrial opening from the lateral to medial side. Retrovesical, dissect the bladder from the lower segment. Whenever there are vessels, so you remove them like it's shown. Only thing is you cannot use any blunt dissection. You have to individually pick up every vessel. It may take any amount of time. You don't have to hurry in that. So you can use general anesthesia or regional complemented with general. It's safe. General anesthesia, absolutely safe for the baby. Now, as I told you, that you give an incision in the upper part and or transverse only, and you deliver the baby by a Ward's maneuver. Now, once you've done that, you remove the uterus and look at the posterior uterine wall. So here, this is a case where this conservative surgery can be done. Now, this was the incision from where the baby was taken out, and everything is operable. These are the three vessels. So they have to be individually ligated. Once they're ligated, see, the rationale now is you don't ligate it distant, the blood supply. You ligate close to the organ. And once you've done that, now en bloc, you remove this piece, and then you have a big gaping, opening in the uterus, and you think, oh, it's so abnormal. But fact of the matter is that this was the niche where the placenta has distended it. So basically, if there is healthy myonutrient below the margin, you can very well go ahead and do it. So here, the corpouterine vessels are ligated and incision is made, and en bloc dissection and uterine construction. This is the whole uterus which is looking open, but 3 U sutures from upper segment to lower, they are done in the first layer to bring it together, and then the second layer. So, it looked very weird, but fact of the matter is that Dr. Jose has reported 200 cases of one-step conservative surgery where patients have conceived again and they have no pass. So basically, you have actually, in this surgery, removed that niche along with the placenta. So basically, if you have healed this inadequately healed wound, so obviously it will not invite pass again. So that is what it was about the one-step conservative surgery. And now hysterectomy is pretty simple. We cannot do one step because maybe it's not needed. Patient doesn't want to keep the uterus. So you can easily do the hysterectomy if the bladder is mobilized or if the placenta is occupying more than 50% of the circumference. That means you cannot save this uterus because you have very small segment of the uterus which will be left. So for total hysterectomy, if you have been able to mobilize the bladder, it is a cakewalk. It's not difficult. Now coming to this category, type 4, where the pus has fibrosis. So whenever there is adhesions between the bladder and the uterus in the form of fibrosis, not neovascularization, this will not, relent. You cannot do cautery, you cannot find the pedicles over here because this is very richly anastomosed. So this you have to take a call. Here you have to take a decision of doing modified subtotal hysterectomy. So one second. So what happens in modified subtotal, once you realize you cannot dissect the bladder, you just leave it, deliver the baby out. Again, if you make an attempt, but you find densely adherent bladder, you don't want the patient to bleed now. So take the decision of doing modified subtotal hysterectomy. Circular incisions are taken around the stump, and before it is cut, proximal control by internal compression of the aorta. That is what they do, so that there is no immediate bleeding from the cut edge. And then once that is done, this is closed because the lower segment is very much around. We haven't, taken care of. So from the posterior aspect, you have to make sure that the posterior wall of the uterus and the lower segment is tightened with the anterior wall. And here, maybe 1 or 2 stitch may go through the bladder, but let's see that we have compressed the lower segment so that, this surgery is complete and patient will not bleed. So basically, I will conclude my talk by saying this placenta accreta spectrum and cesarean section, they go hand in hand. We cannot deny the fact that if we decrease the number of cesarean sections, definitely we'll be subjecting patients to less incidence of PAS. But many times, we have to understand that it is not PAS, but it is only dehiscence and not adherence. A niche in which the placenta implants enlarges the scar tissue for vascularity. Neighbors, that is the bladder or the parametrium, they contribute to neovascularization. These vessels can be doubly ligated and cut, but fibrosis poses maximum risk of torrential hemorrhage. Internal manual aortic compression is safe immediate response to be instituted. To expedite delivery of baby, high uterine hysterectomy and Ward's technique. Now, basically, the advantage of doing this circular incision is if you want to save the uterus, you would have taken the appropriate incision. So, all these things, what to do when, you have to understand the rationale of the blood supply, the disease to be expected. And let me tell you, incidence of percreta is very low. It's not as high as we are afraid of. And recognize early and plan wisely. For this iatrogenic complications, outcomes in placenta accreta spectrum are not determined in the operating room. They are decided in planning and preparedness of teams. Today, mastery of vascular anatomy, topography, and intraoperative surgical staging has transformed the management of this once insurmountable life-threatening complication. Well, friends, I must say this, that every time when you see a case or you, go through preparing a talk, your own concepts become clearer. I hope I've been able to do a little bit of justice to our wonderful teachers. And what I want to share with the audience is that recently Dr. Albaro has shared with me the latest study, which is a multinational study in which they have many centers who are now doing the topographic, classification, surgical staging, compiling their data, and feasibility of doing these procedures, with less complications and less morbidity. So that is going to be out very soon. But I think that a protocolized management of paths is something which all of us can understand, which all of us can do. And I think this was just a trailer. Let me inform you that on 21st of May, we are arranging a master class on placenta accreta spectrum. I invite all of you because Dr. Albaro will be very much present online. So that's it. Thank you so much, Dr. Mandakini, Dr. Archana, everybody. My dear friend, Dr. Anjali, Dr. Padma, and Dr. Mitra, all those from Madhya Pradesh who joined our workshops. Thank you.
Thank you so much, ma'am, for the wonderful presentation. That simply.
If I can just put a word. Dr. Mitra Saxena, it was a wonderful presentation. And yes, we were a part of that workshop. And really, to let you know, so many of our anatomical concepts were clarified in that. It was really great to have your presentation today again. Thank you so much.
Thank you, Dr. Anjali. And the good thing is this, that we had just finished our first workshop in Kolkata, and we were now in Indore. We got a feedback from our girls in Far East. They had already done this conservative surgery and modified subtotal. So it's like validation with actual cases. That is the best thing.
I think we should go ahead. Mitra, excellent lecture. And I'm always remembering your labor room. I visited your labor room, your hospital, and I was amazed to see her multifunctional because one time she was delivering, other time she was cesarean, third time she made bhajias for me. I said, how can you do all these things? And late night we were having bhajia. Again, she's, going to the hospital. I was visiting her hospital for recognition of ultrasound center.
Madam, you are connected to all of us. I said that dil se jude ho aap. And I want to hear sir's lecture, and I will invite sir's comments as well because he's such a fantastic
comments
teacher.
Are very important.
Yeah.
Dr. Virkud, please comment on her lecture and your remarks.
Yeah. Okay. My comments would be, I did hear, and to tell you frankly, it was a nice illuminating lecture for me. Let's put it very frankly, because I was not really aware of this modified subtotal hysterectomy and all these things. So I would really like to attend your next masterclass and to learn more about these techniques.
Yes, sir.
Yeah,
This
but
is
thinking over it, I mean, I'm the type who somebody gives me a new idea, I will first I will not reject it outright. I will listen to it. Then I'll think over it for a few days, and then form my own opinion. And then sometimes it's positive, sometimes negative, but I'll think over it. But I like the idea of whatever the gist of what your lecture I attended is that that lateral approach, because the bladder is many times adherent, and the lateral approach going from laterally, and then when you separate from both sides, you'll be able to see the vessels sort of like a bridge between the bladder and the rectum. So put a instrument below it and lie it at two places and cutting. So that way, separating the blood vessels of the and make the bladder separate. I like that idea. So I really think about it and let you know. And
Sir,
on the
I'm
other,
happy to tell you that
huh,
Dr. Saha, he is
huh,
professor in PGI, Chandigarh. So it's like you people are, teachers. So you all will think on your own as well or get an idea and you have the opportunity to practice it. So Dr.
correct.
Saha was already doing bladder first. He was, like you said, these things
Huh,
he was doing and he came and attended the workshop and it was like endorsement. So I'm sure, sir, you're going to interact with us and I will be inviting you as one of
sure.
our chairpersons or whatever. I will want you to be there for on digital platform for this master class.
Sure, sure. One more comment I can make about this thing. I think you talked about with that case. I also have similar experiences. A lot of these sonologists, first of all, are not aware. They are just they do the exam. I mean, the ultrasound, and they say this is placenta accreta spectrum. Any previous list cases, and I know a couple of cases because I also get a lot of patients almost every day. One or two people, gynecologists, call me for their difficult case, and I have seen cases where they say, "Sir, ऐसा है कि he is diagnosed placenta adherent placenta. What to do? And should I go ahead with hysterectomy and all that?" So I look at all the history and all that, and many times I told him maybe the diagnosis is wrong. You just open and see. And many times we have found out that what actually was labeled as placenta accreta, adherent placenta, and increta, whatever those three levels, actually turned out to be just a simple adherent placenta, and they could separate it and go ahead. Okay, and I
Yes.
know one case where just recently about last month where they have this thing. I said just because the patient was very keen to conserve. I said just conserve. You take her. He said no, sir. I'm scared. She'll bleed and all that. I said I'm taking the risk. This patient was from Bombay Hospital. I said don't worry. Just this thing. We'll observe her. We just did a conservative thing. Just close the thing and didn't remove the placenta and waited. Gave a methotrexate. And after a few days, the placenta just entirely came out. It
Yes.
was not even placenta spectrum. That is how it goes. You
Sir,
understand?
what I want to say is that in this, because it was a very long presentation, Dr. Albaro and Dr. Jose, I have been interacting with them. I have found them fantastic human beings. They have shared their videos with us. There was no time, otherwise I could have shown you videos on personal level. I can, show you
Sure,
their surgeries as well, and you'll be really happy. So
sure,
I'm sure that in you, I have another champion. And
sure.
actually, sir, I
Uh,
got into argument with Dr. Jose. I said, no, sir, internal iliac is a very, he said, no, Mitra, it's a difficult skill to learn. It's easier to understand this and go stay close to the uterus, assess the operability and go ahead. And now I feel, oh my God, he has simplified it for us. It's
correct.
amazing.
Yeah,
Yeah.
we should. I'll definitely try it out and I'll give you back my feedback.
Yeah,
Yeah.
sure, sir. Thank you, sir.
Yeah.
Thank you very much. It was such an amazing lecture, ma'am. Never heard all these things before. And I think that goes for most of the delegates who have joined us today as well. Superb lectures so far. And we also look forward to two more interesting talks by our great speakers. I call upon the chairpersons for the next scientific session. Can I please have their CV? We have with us Dr. Archana Maheshwari, ma'am. She's a secretary of the Ujjain OBGY Society. She's the director of the Balaji Hospital Ujjain, director of the Magada Life Arts Center Ujjain, secretary of the Ujjain OBGY Society. Ma'am is MBBS from Indore. She's done her MD from KEM Hospital, Mumbai. She's the FCPS gold medalist, diploma in gynecological endoscopy in Kiel School. And ma'am has attended many national as well as international conferences as faculty. And she also has, to her credit, the fellowship in minimal access surgery, fellowship in infertility from Israel as well. We welcome you, ma'am. Can I have the next CV, please?
Thank you.
Yes, we have with us our second chairperson, Dr. Kirti Thonde, ma'am. She's the director of the Nirmaya Nursing Home, Gwalior, practicing for the last 34 years. Ma'am is the president-elect Gwalior OBGY for 2026 and 27. Ma'am has a special interest in ultrasound and infertility. May I please request the chairpersons to introduce our speakers? Thank you.
Kirti ma'am, can you please introduce our speaker, Professor Ajit Virkud, sir?
Ma'am, we can't hear you. You are mute. You're on mute.
Thank you very much, Dr. Rupali. It gives me immense pleasure to introduce Professor Ajit Virkud, sir. And he doesn't need any introduction, and such a great teacher. And he's an innovative gynecological surgeon. He's devised Virkud's composite sling operations, and he's an author of 5 obstetrics and gynecological textbook that are very popular with UG and PG students. He is facilitated by Her Royal Highness Queen of England in 2006 for his contribution to the only textbook published by FIGO on the subject of postpartum hemorrhage, now in 2nd edition. He is past president of Mumbai Obstetrics and Gynecological Society 2007 to 8. Successfully, he is a YouTube mega influencer, and obstetrics and gynecology is his profession, but teaching is a passion. So I welcome you, Dr. Ajit Virkud, sir.
Yeah. Thank you very much. I hope you can hear me.
Yeah. Yes.
Thank you. Yeah. Before good evening, first of all, good evening to everyone. Before I share my screen, let me wish all the best to Dr. Archana Basir for her forthcoming presidential election. All the best. And then I'll just, since we are maybe running a little late, so I'll just share my screen and start my presentation. Okay. Distinguished colleagues and organizers, thank you for this invitation and for the trust it represents. I want to begin not with a statistic, but with a clinical scenario that I believe most of you in this room have encountered, even if you have not always recognized it for what it was. A 32-year-old woman who had a cesarean delivery 4 years ago presents with a persistent post-menstrual spotting lasting 7 to 10 days after her period appears to have ended. She has been trying to conceive for 18 months without success. Her CA 125 is mildly elevated. Someone has suggested she might have isthmosceal or endometriosis. She is frustrated, anxious, and beginning to lose confidence in us. I know this patient, you know this patient, and the reason her diagnosis has been missed is not because the condition is rare or because the investigations are inaccessible. It is because we, as a specialty, have been slow to recognize that this cesarean scar we place so routinely leaves consequences that do not always announce themselves immediately after delivery. Today, I want to talk about 3 of those consequences: the isthmosceal, cesarean scar endometriosis, and the impact on future fertility. And I want to argue firmly but constructively that understanding these sequelae is not a subspecialty concern. It is a core competency for every practicing obstetrician and gynecologist. To understand the magnitude of what we are dealing with, we must confront the epidemiological reality of cesarean delivery in the 21st century. The global cesarean rate has more than doubled over the past 2 decades. In the year 2000, approximately 12% of all births worldwide were by cesarean. By 2023, that figure had risen over 21% globally. India, with its enormous birth cohort, now performs more cesarean deliveries annually than any other country on earth in absolute terms. The World Health Organization considers a cesarean rate about 10 to 15% as offering no additional survival benefit to mothers or neonates. Everything above that threshold represents surgery without mortality advantage, but with complication risk that compounds with each subsequent cesarean delivery. We are, by any measure, in the midst of cesarean epidemic. And the long-term consequences of that epidemic are only now beginning to be fully appreciated by our specialty. The uterine scar created by cesarean delivery is not a normal event. It is a permanent structural alteration to an organ whose architectural integrity is fundamental to menstruation, implantation, placentation, and the safe conduct of future pregnancies. The scar heals or fails to heal under the influence of surgical technique, closure method, infection, hemostasis, and individual tissue biology. When healing is imperfect, which occurs with greater frequency that we have traditionally acknowledged, three major categories of long-term consequences emerge: the isthmosele, Caesarean scar endometriosis, and a spectrum of reproductive sequelae ranging from implantation failure to life-threatening placentation disorders. It is important to recognize these three key facts. 21 million cesarean deliveries are performed globally per year. Isthmosele develops in 24 to 70% of cesarean scars depending on diagnostic modality. Cesarean scar endometriosis account for 15 to 50% of all abdominal wall endometriosis cases. The magnitude of this problem is not marginal, it is systemic. At the outset, I will discuss the most prevalent of them. The isthmosele, also known as uterine niche or Caesarean scar defect or Caesarean scar diverticulum. It is a wedge-shaped myometrial defect located at the site of a previous Caesarean uterine incision. It represents an area of incomplete healing where myometrial tissue has been replaced by disorganized fibrous scar tissue that fails to achieve the structural continuity and thickness of normal myometrium. As illustrated in this schematic representation of a longitudinal section of the uterus and cervix, the defect can manifest in various forms, including triangular, rectangular, semicircular, circular, droplet-shaped sac or pouch. Occasionally, the defect may encompass inclusion cysts. Histologically, the base of the defect contains disordered fibrous tissue, chronic inflammatory infiltrate, and ectatic engorged blood vessels. The overlying endometrium, when present, is atrophic and poorly functional. The surrounding myometrium is thinned, and the cavity of the defect communicates directly with the uterine lumen, creating a dependent pouch that fills with menstrual blood, debris, and mucus during every menstrual cycle. The prevalence of isthmosele is frankly alarming. Transvaginal sonography reveals defects in 24 to 56% of women following a single cesarean delivery. When saline infusion sonography is used, a more sensitive technique, detection rates rise to 56 to 70%. In women with two or more prior cesarean deliveries, the prevalence of a significant defect exceeds 70%. Keep in mind, it is only in the last 15 years has the specialty begun to systematically characterize what those scars look like years later. Caesarean section scar defects may have occurred in significant numbers in the previous decade, that is, in the previous century, or when we were very active in our obstetric practice. But except for invasive techniques like histography, we had no way of diagnosing these scar defects in those days. The clinical consequences of isthmosele fall into three interconnected domains. The first is blood-stained mucoid discharge persisting for 4 to 14 days after the apparent cessation of menstruation. Menstrual blood pools in the dependent cavity or the defect, drains slowly through the narrow communicating ostium, and trickles out over the subsequent days. This is not dysfunctional uterine bleeding, it is structural and it will not respond to hormonal manipulation. The second domain is pelvic pain. Dysmenorrhea or chronic pelvic pain or dyspareunia are significantly more prevalent in women with isthmosele than in women with an intact, well-healed Caesarean scar. The chronic inflammatory changes at the base of the defect, the disordered vascularity, and the local biochemical environment contributes to pelvic pain sensitization that is often poorly localized and may predate any diagnosis by years. The third domain is reproductive failure, and it is this domain that most urgently demands our attention. The isthmocele creates a hostile implantation environment by accumulating fluid that spills retrograde into the uterine cavity during the post-implantation window, by altering the local cytokine milieu, and by producing chronic endometrial inflammation. The result is impaired implantation rates, higher first trimester miscarriage rates, and the specific risk of Caesarean scar ectopic pregnancy. Transvaginal sonography in the mid-luteal phase, when the endometrium is thickest and the defect most clearly visible, is the first line diagnostic modality. Identify the triangular anechoic defect at the anterior low uterine segment. Measure the residual myometrial thickness at the base. A residual myometrium of less than 2.5 millimeters is associated with significantly higher rates of uterine rupture in subsequent pregnancy and is a threshold that should prompt discussion of surgical repair before future conception. Saline infusion sonography substantially improves sensitivity. Hysteroscopy provides direct visualization of the defect and is invaluable before surgical intervention. MRI is reserved for complex cases, particularly where Caesarean scar ectopic or adenomyosis coexist. When it comes to management, the first thing I want to mention is that not all isthmoceles require intervention. The woman with mild spotting and completed family may reasonably be managed with explanation and follow-up. The woman with significant bleeding, pain, or infertility, or the woman with thin residual myometrium planning a future pregnancy requires surgical correction. Hysteroscopic isthmoplasty achieves symptom resolution in approximately 80 to 85% of cases for abnormal uterine bleeding. For women with very thin residual myometrium requiring structural resolution before future pregnancy, laparoscopic or combined laparoscopic hysteroscopic repair with full thickness myometrial reconstruction provides the most durable anatomical result. Caesarean scar endometriosis, also called abdominal wall endometriosis or scar endometrioma, arises from the implantation of endometrial glands and stroma into the tissues of abdominal wall, subcutaneous fat, facial layers, and occasionally muscle at or near phalansteal incision. The mechanism is direct transplantation during cesarean delivery. Endometrial tissue shed into the operative field during uterotomy is inadvertently implanted into the wound at closure. This is called iatrogenic endometriosis. We create it, and its incidence is rising in direct proportion to our cesarean rate. Caesarean scar endometriosis accounts for 15 to 50% of all cases of abdominal wall endometriosis in published series. Its incidence following cesarean delivery is estimated at 0.03 to 1.7%, a wide range that reflects inconsistent active case finding and the frequency with which these lesions are misdiagnosed. The clinical presentation is characteristic. A woman presents with a painful lump at or near her Caesarean scar. The pain is cyclical, worsening in the days before and during menstruation, improving between periods. The lump may increase in size during menstruation and diminish afterward. There may be overlying skin discoloration, a bluish or brownish tinge. The nodule is firm, often adherent to the underlying fascia, and exquisitely tender on direct palpation during menstrual phase. The tragedy, and I use the word deliberately, is that the average time from symptom onset to correct diagnosis in published series ranges from 2 to 5 years. During that interval, these women are told they have a wound hernia, a lipoma, a seroma, or a lymph node. They undergo ultrasound examinations reported as non-specific soft tissue masses. They are referred to general surgeons who excise lesions without recognizing the diagnosis or achieving adequate margins. Patients return with recurrence. and they return angry because somewhere in someone's consultation room, the right question was never asked. A detailed clinical history is helpful, and specifically one question that is too often forgotten. Does your pain vary with your menstrual cycle? That one question in context of a scar nodule changes everything. Ultrasonography of the anti-abdominal wall typically shows a heterogeneous hypoechoic mass with internal vascularity on Doppler. MRI is the most informative imaging modality, demonstrating characteristic T1 high signal on fat suppression sequences, reflecting hemorrhagic content, and the heterogeneous signal of repetitive cyclical bleeding. Fine needle aspiration cytology has a sensitivity of approximately 77% and can provide preoperative confirmation, though a negative cytology in the context of convincing or characteristic clinical history should not deter surgical management. The treatment of choice of Caesarean scar endometriosis is wide local excision. Complete surgical removal with a minimum 1 centimeter margin of healthy surrounding tissue. These lesions are frequently adherent to the rectus fascia and may extend into the rectus muscle and occasionally involve the bladder dome when they arise from the inferior phalansteal incision. Preoperative MRI to define the extent of involvement is valuable in planning the appropriate surgical approach. Following adequate wide local excision with appropriate margins, recurrence rates are approximately 4 to 5% at 5 years. Following inadequate excision, they climb to 20 to 30%, which is why the initial surgery must be performed correctly by a surgeon that is an experienced gynecological surgeon who understands the diagnosis. Medical separation, that is combined oral contraceptive pills or GnRH analogs or Dinoges, provides symptomatic relief but does not eliminate the lesion and carries high recurrence rate upon cessation. It is thus a temporary treatment.
Sir, there is no voice.
Yeah, I'm just showing the thing. I think there's some.
You can comment on it. No problem.
Yeah, we cut open the lesion which was removed and it showed occult blood. That is what we wanted to show. And I think I will just go ahead because it probably this is just the entire video showing the thing. And
this is adhere to rectus.
Yeah, it was adherent to the fascia. And here what we're just checking again is whether any nodule or anything is left behind or anything which is looks suspicious of endometrial nodule. So we just confirm everything and then only close. That is very important. Perhaps no aspect of the long-term consequences of cesarean delivery carries a greater clinical burden than its impact on future fertility and reproductive outcomes. The uterine scar is not merely a cosmetic concern or a source of menstrual symptoms. It is a structural alteration that affects every subsequent pregnancy in ways that range from subtle impairment of implantation to catastrophic obstetric hemorrhage. The isthmocele creates a local intrauterine environment that is hostile to implantation. Accumulated fluid within the defect alters the biochemical composition of the endometrial fluid during the peri-implantation window. Studies have demonstrated elevated melanoproteinases, reactive oxygen species, and inflammatory cytokines in the uterine fluid of women with significant isthmoceles. These are changes that impair endometrial receptivity and increase early pregnancy loss. In women presenting to infertility clinics with unexplained IVF failure, the prevalence of clinically significant isthmocele ranges from 14 to 26% in published series. This is not coincidence. It is a classical relationship that deserves to be part of the standard infertility workup for any woman with prior cesarean delivery who has been failing to conceive. Saline infusion sonography or hysteroscopy should be a standard component of the infertility workup in any woman with one or more previous cesarean deliveries presenting with unexplained subfertility or recurrent IVF implantation failure. This is a clinical practice recommendation. The most important message I want to leave you with is this. The most effective prevention for isthmocele, Caesarean scar, endometriosis, and Caesarean related reproductive failures is the Caesarean that was never performed unnecessarily in the first place. I recognize that reducing the Caesarean rate is not a simple clinical prescription. It involves patient preferences, medical legal fears, institutional incentives, and health system structures that no individual clinician can address unilaterally. But within our individual clinical practice, every one of us can, and I believe must, critically evaluate each indication for Caesarean delivery, support vaginal birth after Caesarean in appropriate candidates, and ensure that when Caesarean delivery is necessary, it is performed within the technique most likely to produce a well-healed scar. As far as the debate about single layer versus double layer uterine closure is concerned, the evidence now strongly favors double layer closure for long-term scar integrity. Single layer closure is associated with higher rates of myometrial deficiency, thinner residual myometrium, larger niche dimensions, and higher rates of placenta accreta in subsequent pregnancies. The 2 to 3 minutes saved by single layer closure do not justify the reproductive risk imposed. My mandate for this presentation is to elucidate the gynecological sequelae of cesarean delivery. However, my presentation would be incomplete without at least mentioning pregnancy-related consequences of cesarean delivery, especially cesarean scar ectopic pregnancy, placenta accreta spectrum, the most catastrophic consequence, and uterine rupture, the laboring scar. Due to time constraints, I am unable to delve into these topics in detail. However, if you are interested in gaining a comprehensive understanding of these conditions, I recommend watching my YouTube channel. The Cesarean scar is not a sealed chapter in a woman's obstetric history. It is an ongoing clinical story connecting the delivery room to the gynecology outpatient clinic, to infertility consultation, and to the next antenatal booking appointment, and to the multidisciplinary team managing placenta accreta at 34 weeks. Every one of us in this room is a part of that story, whether we work in obstetrics and gynecology, reproductive medicine, or maternal fetal medicine. The consequences of cesarean delivery are long-term. Our responsibility to recognize and manage them must be equally long-term. Understanding the isthmocele, the scar endometrioma, and the full spectrum of reproductive sequelae of cesarean scar pathology is the clinical knowledge that allows us to do justice to the trust that our patients place in us in one of the most consequential moments of their life. I will end with this quote: the uterine scar heals in silence. Or does it always? It is our responsibility to listen. Yeah.
Thank you very much, sir. Ajit Virkud, sir. It is a masterpiece, I can say. It is a masterpiece and presented in a beautiful style. This style, first time I came to, recorded, but it looking so beautiful and I self-explanatory. I think everybody enjoyed your, and it was, visibly also we could connect to so many. I could connect to mostly to the rupture uterus because maximum rupture uterus in our time we used to do, and a lot of experience with that is there. And I think I would like to invite the their experiences. Chairperson Dr. Kirti Mitra, for your this thing.
Thank you, sir.
Yeah.
Thank you, sir. It was an excellent presentation. Actually, sir, we come across with esteemed so often because I'm doing ultrasound for last so many years, and I have come across, and I was always worried about it, and the endometriosis scar also. Sir, I would like to ask you, what is the cutoff for this esteemed? Because with recurrent abortions and with even the post cesarean cases, when we do transvaginal sonography, and we see a little bit thinning of that particular scar area and the anechoic area. So what is the cutoff, sir, where we should explain our
Yeah.
patient?
Correct. So I think I have already mentioned it in my talk. So the reported threshold is the base that is from the defect right up to the serosa. What is the width? Okay, and if it is
Thickness.
more than 2.5 millimeters, then
2.5.
that is considered as a threshold. Okay, sorry, so less than 2.5 millimeters. That means the amount of myometrium is so thin that it is likely to give rise to rupture or problems. Okay, and as far as the post-isthmosele symptom, as per the clinical symptoms are concerned, which is spotting and all that, that is more dependent on the type of cavity and all, because the larger the cavity, more will be the collection, which will then drain in the post menstrual period as bleed spotting. You understand? So that is how it goes. Yeah.
Thank you,
If
sir.
there
Thank
are
you very
any
much.
other
Thank you,
questions,
sir.
yeah, if you can give me a few more minutes, I can talk a little more. Mention. See, first of all, when at my level, if I'm giving, that happens almost every time when I'm asked to talk. Many times nowadays, I'm not very happy about participating, giving a talk, is because you are asking a marathon player to run. Are tu 100 meters run karega kya? Because you give me a topic and I like to talk for 1 hour, 2 hours. That's how we teach our students. And then he says, sir, kitna time? 15 minutes, 20 minutes. I say,
नहीं
इसमें
सर,
तो
सर आप हमारे ट्यूसडेज में
that
टीचर्स
is
में
like asking, sir,
पढ़ाएंगे 1 घंटा.
if I can use a very sort of
That
funny
was a
language,
pleasure listening
that
you.
is like just asking me to do foreplay without doing the actual act. you know. So anyway, but just one more point I want to tell you. That two-layer closure. I won't go into details, but please remember the second layer should be what is known as Halstead repair. And if anybody interested can contact me, and I can instead, and there are my videos on it. So please do a second layer closure with Halstead. And as far as endometriosis goes, nowadays the current recommendation is that we should even close the serosa, because many of the students nowadays are just doing single layer closure, not closing the bladder serosa
We are doing.
flap and all that. So all those things, if you ask any endometriosis specialist who is doing endometriosis cases, will tell you, nahi, nahi, you have to close properly in layers. So things have changed. So I want you to remember that. Yeah.
सर
Thank you, sir.
सर
Thank you.
एक कमेंट बोलेंगे
हाँ.
कि I loved this presentation, and actually when people of your stature bring the attention of everybody towards something which we ignore. Isthmosele is actually troubling people, and it is again like placenta accreta spectrum. Either it is ignored totally or it is over treated. Just investigate it and correlate it to the type of discharge. A woman will be having foul smelling, sticky, bleeding, different from fresh bleeding. You have to understand कि ये तो मैला
Yeah, it's
गंदा
old
रुका
old
पड़ा
blood.
है.
Yeah.
So
Brown
basically
discharge.
speaking, yeah. And sir, I will share with you the repairing techniques of the scar diasis also, which is phenomenal, with the Dr. Jose has taught us. And what I am going to invite you on my platform, 1 hour of Dr. Ajit Virkud.
Yes,
Tuesday
I would love to.
Yes.
सर
I would love
28 अप्रैल को आप क्या बताएंगे ये बता दो, हम अभी से फ्लायर छपा देंगे.
Yeah, you can DM me, and
आज ही बात कर लेती हूँ, आज ही बात कर
yeah,
लेती हूँ.
a little busy with many things, but I'm sure
No, it is to be, our timing is very set, 8 to 9 p.m. And
okay.
after that, open house. All the people who have
Yeah, and
bothered to come in will ask you questions.
I love
Another
people
thing,
ask.
sir, I will ask your thing. See, we've had this coronis trial and falana dimkana for cesarean. Now I think we all in India should design a study, because now we have transvaginal scan. So, like with you people making the protocols, we should be doing the assessment of the scar at 6 weeks and at 6 months.
Correct.
Right? And then say, this is our healing. हमें अपना रिजल्ट भी तो देखना चाहिए. उठाया और, and I feel Vicryl is one of the reasons for scarnish. I feel chromic catgut was a better suture material than Vicryl. I will invite your suggestion on that.
Yes, we will talk about it. I am really keen to talk about the Halstead technique, which many people I'm sure are, even students, are not aware of, and it's one of my favorite techniques of closing doing, which is what people are not using. And whenever I discuss, I take lectures on cesarean delivery and all that. I talk a lot about it, and almost nobody knows about this, my technique of closing the uterus, which is a little different from everybody. So I would love to talk about it.
So what you prefer, chromic catgut or Vicryl? for
See,
Cesarean closer?
it's a nice question. See, everybody using Vicryl, and now we do use, to be honest, I do use Vicryl
10.
only. Yeah, 10 Vicryl. But the point I want to make is that, okay, the first reason is that chromic category is nowadays almost not available. That is the main problem. Okay, so chromic category is also good, and our time, Dr. Mitra, we would also endorse that. We have used catgut at our time. So ऐसा नहीं है कि catgut नहीं चलता है.
सर हम कैटगट यूज करते थे तो वीबैक सक्सेसफुली अपनी करा सकती थी. आई एम सेइंग आई एम द सेम सर्जन. आई यूज द सेम 2-layer closure.
Yes.
Not locking. My only thing that has changed is chromic to Vicryl. I am not able to do VBAC in my own patients.
Correct.
That's my observation. So self-audited.
So more than the suture material, what is important is that you do not strangulate. Do not strangulate the uterus. That is what many people. इतना tightly करते हैं. They are so scared of any bleeding, oozing. तो tightly ना करते हैं. I said you're strangulating the uterus. You can't do that, and that is what is going to create problem later on. You know, that is a very important thing. Yeah.
Thank you. Okay. Thank you, sir.
Thank you.
Sir, it was a wonderful lecture. Really.
One point about Dr. Mitra, I think, talked about my presentation. Please see, if you go abroad, and especially people like us who are who are invited all over, when we talk, you see, you go abroad, everybody is using fantastic presentation. Abhi India mein itna tum ordinary PPT slide दिखाते हो. We use Apple Mac, we use Keynote, we use so many different things. Technology advanced. थोड़ा कुछ सीखो और कुछ तुम्हारा अच्छा presentation बनाओ. You see the background I'm using in my slides. It is a moving background. It is not static. There are so many things we are doing. And by the way, I'm not trying to praise myself. What I'm trying to tell you is that if you're interested in all these things, DM me and I can teach you. I'm willing to teach you whenever I have time. That's what I want to say.
Sir, you take a class for us.
By the way, I take lectures on presentation, how to make presentation, and I don't call it PPT
like
because we
have
don't
you
use
in
PowerPoint
Gwalior,
anymore.
sir. Please spare time for Gwalior.
Yes, sure.
First, let him treat all of us on this platform, and then Gwalior.
If you ask me, I want sir in the labor room.
My first
deliver a patient.
What did Archana say?
If I'm saying, sir, if you ask me, I want sir in the labor room when I'm delivering the patient.
Okay.
While doing
Cesarean. You're God for us.
Chalo,
go ahead.
I think we should do a Cesarean workshop, madam, with sir.
Yes, I love one of my favorite topic is Cesarean. I can tell you a lot of things. Caesar is one topic where everybody thinks, अरे उसमें क्या है, हमने तो हजारों किया है, हमको आता है बहुत. Now I will teach you things which you all don't know.
Yes,
that's my confidence.
Do you close Rosa in every case?
Well, no, I think we should go ahead with the.
Yeah, go ahead. I think it's too much.
Thank you, sir. Thank you.
Thank you, sir.
Amazing.
Sir is very.
Thank you, sir.
Please, you can call him and take and see his YouTube video. Sir, thank you very much for that honor of being on our platform, and we expect you to be there for many more at World Congress also.
Sure.
Yes, thank you very much, sir.
Yeah.
We move on to the next scientific session. May I call upon Dr. Archana Maheshwari, ma'am, to introduce our next speaker, Dr. Gauri Karandikar.
Sure. Good evening, ma'am, everyone. I'm very grateful to Dr. Mandakini Megh, ma'am, Archana Basir, ma'am, and Anju, ma'am, for giving me opportunity to chair the session on important topics and visit great stalwarts. So I'm privileged to introduce Dr. Gauri Karandikar, madam. She is director and lead consultant, Karandikar Hospital, Nasik, India. She's a managing committee board member, PCOS Society of India. She's a joint secretary of AMWI. She's a secretary in Society of Adolescent Health and Medicine. She was president Nasik OBGY Society in 2023 to 2024. She has been awarded with many medals and papers and all. She was PCOS champion. She got PCOS champion award. Sorry, ma'am.
We can proceed with the presentation. I think we are.
Okay, ma'am. Over to you.
Thank you so much for your introduction.
Over to you, ma'am.
Yes, sir. Can I just share my slides? So before I start my presentation, I would like to thank this whole August audience for being here with us today as a joint secretary of AMWI and with Dr. Megh at the head of this institution, of this organization. I would like to thank her for giving me this opportunity, and the all Madhya Pradesh organization for inviting me today. And I would like to tell you that also it's a real pleasure to be speaking with Dr. Archana, Dr. Mitra, Saxena, and Dr. Virkud. My first presentation in my life as a resident was my slides. We had those slides at that point of time, and my first slide was made. The first slide set was made by Dr. Virkud for me, and I presented in AMPOGS in 1995 when I was a first poster, and I had no idea. And Dr. Dastur had, sent me to Dr. Virkud's house, and that was the first time that I took the slides from sir. So I'm so blessed, that today I'm talking in front of sir, and I will definitely attend your class, sir, to see how the screens are moving at the back, and I will definitely want to know how to make them. So thank you so much, sir. My journey has begun with you. So moving to this important topic that we have for today on post-cesarean section infectious morbidity. Now, recently in 2025, under the FICO Committee on Infections, Dr. Megh is on the committee, and I was on the subcommittee as she involved me into this project, and we had an excellent paper on post-cesarean section infectious morbidity. So if anybody is interested, I could share the paper also with you, which is a comprehensive paper on post-C-section infectious morbidity. Now, why is it so important? We've all discussed all this till now. Is about that there is a rise in the global C-section rate. Yes, we have reduced the mortality and morbidity associated with pregnancy and intrapartum events. But yes, as Dr. Virkud rightly said, that beyond a particular incidence rate, it is not really helping us to help the morbidity and mortality, getting the morbidity and mortality rate down as well. At the same time, there is a 7% surgical site infection rate, and worldwide almost 20% rate in the low middle income countries, and almost 75,000 maternal deaths per year are linked to postpartum infections. Now, India is having the highest and fastest rising C-section rate in the world. As far as like Dr. Megh said, that it is very high in some states. And of course, if the number of C-sections increases, we have the complications and infection rates also going up in the similar way. What are we looking at in this whole scenario is what is the spectrum of the C-section infections that we are seeing. One is the surgical site infections, which we can see from 3 to 30 days post-op. The incidence is almost 2 to 20.5%, where we have superficial incisional or deep incisional infections. Then endometritis, which is generally seen within 10 days postpartum, and which is of polymicrobial origin. Then urinary tract infection, and the post C-section sepsis. That is something which we are really worried about, and we don't want. Which can be life-threatening, and which takes our patient to the ICU. Now, by definition, this sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection, and that is why this is the WHO definition that has been given to sepsis, and that is why we need to know that this is a dysregulated host response, and we have to work on that. In simple ways, how would we diagnose in sepsis is like a SOFA score or a quick SOFA score, where the respiratory rate more than 22, GCS less than 15, and the systolic pressure less than 100. That is something we have to keep in mind. Now, the risk factors that we have that are likely to cause these infections: the preoperative status of the patient, where we have obesity, diabetes mellitus, anemia, HIV, or any immunosuppressants, previous surgical site infections, GBS colonization, prolonged labor, and multiple vaginal examinations. Very important. Also, intraoperative cases where there is an unscheduled or an emergency section, a prolonged operative time, excessive blood loss, inadequate antibiotic prophylaxis, which I will come to later, a second stage C-section. Now, a second stage C-section is something which is also known to weaken the scar and the healing. And the post-operative period, where there is a wound hematoma or premature or a poor wound hygiene, prolonged catheterization, prolonged hospital stay, and most important is a delay in the recognition of the sepsis. What are the main things that we are actually looking at? What are we trying to see in this is one is that we are trying to look at is how can we prevent this. So first thing is the antibiotic prophylaxis, and the antibiotic prophylaxis, we have the first generation cephalosporin or penicillin to be given 30 to 60 minutes pre-incision. That is very important. Second is the skin preparation has to be done well, and leave the chlorhexidine alcohol preparation for at least 3 minutes. A vaginal preparation done pre-C-section is very important. Glove change at closure, that is what data is telling us, that team members change their gloves after the delivery of the placenta and before the closure of the abdominal wall. Wound management, correct suturing techniques, and again we come back to the point of unwarranted C-sections, that is standardized labor management, promote VBACs. And most important is training of the operation theater team. It's very important that we are trained, we train our staff, we train our juniors with the right techniques of suturing, with the right techniques or the right indications for C-section, and also, management aseptic techniques in the operation theater. Antibiotic prophylaxis, like I said, was the guidelines given by various organizations talk about the first generation cephalosporin or penicillin to be given 30 to 60 minutes before the skin incision and not after the cord clamp. In an emergency case, it can be given as soon as possible. In those who have penicillin allergies, then clindamycin with gentamicin can be preferred. Now, in high-risk cases, we need to increase the prophylaxis, or we need to have some additional medications for that, like in a prolonged PROM, add azithromycin for chorioamnionitis, ampicillin with gentamicin works well. In obese patients where the BMI is more than 40, we increase the dose of the antibiotic. It is important that if unless the surgery has lasted for more than 3 hours, there is no need to increase the antibiotic or continue the antibiotic beyond 24 hours. And because what we are also going to face is not only the C-section infections, what we are looking at is the high risk of AMR, that is the antimicrobial resistance, and that is going to create havoc, say by 2050. So what we are looking at, as I mentioned, the skin preparation, very important. Allow the drying time of 3 minutes. Hair removal is not really important. Clippers should be preferred over razors. The umbilicus should be clean, which is one of the sources of infection. Vaginal preparation is also important. A vaginal wash, a cleaning, but it cannot be a multiple vaginal cleaning. Only a single vaginal cleaning just before starting the procedure. It reduces the C-section endometritis by 50%. Then glove change, like I said, double gloving, and also changing it after the delivery of the placenta. Wound closure techniques, important to have evidence-based practices. Close the subacute fat if it is more than 2 centimeters, and subcuticular continuous sutures over interrupted. And also wound drains only if there is a large dead space or no routine drain needs to be really put in. Now, this was a good one, a traffic light approach for a clinical severity classification, where we have this green light. It is taken from the NICE guidelines, on basis of the NICE guidelines. A green, which talks about a local infection, just a wound erythema, localized cellulitis, temperature more than 38 within the first 24 to 48 hours only, no systemic signs. So just wound care, oral antibiotics, and close monitoring. And amber light talks about a systemic infection where the temperature is more than 38 degrees beyond 48 hours. There is tachycardia, rising WBC count, lower abdominal pain, tenderness. And now it's a time to act, step up the antibiotics, send for cultures, and also for urinary cultures if required. Then a red signal if the SOFA score goes beyond 2, the systolic blood pressure less than 90 or MAP less than 65, a lactate of more than 2 millimoles per liter, and you can see the patient's general condition deteriorating. It's important to act fast and then activate the sepsis bundle and go for an ICU or the HDU's unit. Now, how the surgical site infections, it's important to open and explore the wound, remove the sutures or staples, debride the necrotic tissues, obtain a wound swab, normal saline irrigation for the wound, avoid hydrogen peroxide in deep wounds, and assess the facial integrity. For a pack of primary closure, for a superficial one, a wet or dry dressing, wet dry dressing for a deep, maybe a vacuum therapy could be considered, and then reassess for a delayed closure. Antibiotics, use them diligently, use them correctly, and that is most important, is rely more on cultures, and then choose the antibiotics. To prevent endometritis and in sepsis, the first line that has been recommended by ACOG is the clindamycin. Now, we very rarely use clindamycin as the first drug of choice in most of our obstetric units, but in clindamycin, gentamicin, in case of already endometritis and sepsis has set in, then alternatively ampicillin or piperacillin-tazobactam, and then depending upon the culture, we need to move ahead an ultrasound pelvis to rule out any collection, hematoma, dehiscence, or surgical drainage. And what is important is recognition on time and action on time. Now, the sepsis management, the 1 hour bundle that has been talked about is in the Surviving Sepsis campaign, and the FIGO 2025 paper is about measure the lactate, take blood cultures before antibiotics if possible, broad spectrum antibiotics, IV crystalloids or fluid replacement, vasopressors at the time at an appropriate time, and time is critical. Every hour of delay in antibiotic increases the maternal mortality by almost 7%. So we need to act on time. In India, we have some specific considerations, that is the rising C-section rate, as we just discussed with the earlier speakers. LSCS on maternal request needs counseling, like ma'am was also saying, we had the Muhurat sections that are coming up, and we don't want to go through labor. People are worried. So I think somewhere we are not able to give respectful maternity care, or don't have enough counseling time, or something is going wrong. We need to even, self-introspect what is going on. Also, the antimicrobial resistance burden, that is something which is very important, and India is a global AMR hotspot. The escape pathogens are prevalent in most of the hospital settings, and it is very important to avoid, empirical higher antibiotics as a first line as well as possible. It's important that, small changes in our practices like glove change and vaginal cleaning, all these are important, and small changes can really make a big change in the long run. So antibiotic prophylaxis needs to be available to all the women regardless of their income, and very important is the surgical safety checklist. It has been proven to reduce the surgical site infections if diligently followed. India also, we have this common problem of anemia, something which is very easily modifiable. Optimize the hemoglobin before the elective C-section. And very, very important is VBAC promotion, where there are good success rates. Even if we have been using mitral, we still have better rates. It is still possible. It is, of course, it's not a single factor, it's a multifactorial stress on the obstetrician and the team when they are doing this VBAC in private setups. But yes, we need to standardize our labor protocols and the monitoring techniques, and try to promote VBAC as much as possible, and also counsel primary para against liberal C-section and request. Important again, follow antibiograms for empirical therapy in local ICUs, de-escalate within 48 to 72 hours of cultures, and no routine post-op prophylaxis beyond 24 hours. So reducing unwarranted C-section, again, like we discussed, everybody has discussed this earlier, is very important. So we need to standardize the labor management, use tools like that have been devised, to avoid C-sections. Second stage, support with operative vaginal delivery. Now something is, that we are learning in workshops, something which we did so routinely when we were as residents, vacuums and forceps. I think we need to, have more training sessions, and more easily we should be doing operative vaginal deliveries, promote feedback. External cephalic version is something which, again, I think seniors we have seen them doing this, and we need to promote this more and more. And more important is that, we should have an audit in our own associations, in our own hospitals, about why this C-section was done, could it be prevented? And then all of us, now we are using the Robson classification, and we need to audit it. So just just a summary: stratify the risk pre-operatively, pre-incision, prepare well along with the surgical safety checklist. Intra-op, we should follow safe surgery methods. Post-op, monitor and detect, check the wound at 24 hours and discharge, educate on warning signs, no repeat and routine antibiotic, monitor temperature and treat promptly. We need to open check the wounds, give IV antibiotics if we had, check, do the SOFA score and see how it is working, and also assess the patient. So the post-C-section sepsis incidence is 7% globally and up to 20.5% in low middle income countries like India. So that is something which we need to really be careful. Avoid unwarranted C-section. I think this is something which we must take home, and also recognize sepsis early. That is very important. So that is what we need to, in prevention of sepsis, small steps can really lead to we can save lives. And I think every life matters. And I think all of us who are here gathered today definitely agree that yes, every life matters. And I think that is the reason for which we all have come here today and we are discussing such an important topic. So I would like to end my talk here. As the Joint Secretary of AMWI, I would request all of you to please join hands and become members of AMWI. This is an association of medical women in India. Although we have invited Dr. Virkud sir here because we are incomplete without men. So we will all take this together. Megh Madam has made a 3-year plan where we are going to work on 4 very important topics on menstrual hygiene and health, NCDs, violence against women, and mental health. And we are in this first year, we are trying to work for us, for medical women. We are ourselves neglected. And if you see, we have our juniors, our medical women, we need to take care of ourselves first. We put on our oxygen mask first, then we can help the others. So I would urge all of you to become our members and, to help us to take this mission forward. It is going to take the stage in 3 years' time. So we as collectively medical women in India, we are the biggest workforce that can stand behind her. And, we can, whatever little impact we make in India, I think it will spread through the world. So I would really urge you all to join us all. And thank you very much for allowing me to talk and for inviting me to this webinar.
Thank you, ma'am. Thank you for an excellent and practical talk on post-dialysis infection following LSCs. The key message of prevention through timely antibiotic giving and strict asepsis like vaginal preparation, skin preparation, change of gloves. These are very practical points you have emphasized, along with early recognition and timely management was very well emphasized. Thank you so much, ma'am.
Gauri, I will like you to, in between I have gone, my link is gone. Gauri, I would like you to show the paper if you have it on the email or something like that. Gauri?
Yeah, I'll just check, ma'am.
How to become a member?
We will share the form on this platform only.
Okay.
So please apply from Ujjain, Gwalior, many members are there. And we want to open a Rewadi chapter. Mitra, we long time back, we have, said that Gwalior chapter is already existing. Ujjain chapter is existing.
We will do that, ma'am. We will do that. Surely.
Yes, it's so nice.
Okay.
Somebody was asking me, can men become members or advisors?
Yeah.
Advisors.
Associate members, sir, because without men, Gauri has already said, without men, we are incomplete. So that membership form we will share, but I want to just show you the sir paper. That paper was a FIGO Committee of Infections, and paper was so much appreciated, and that is our international publication on the infections in pregnancy. Later on, Gauri, you send it to Dr. Virkud, Mitra, everybody, you share the paper.
I'm just opening it. Just a minute, ma'am.
Because it's a wonderful paper. And I think so many country heads, they put their head into it and then they came out with this paper. Sir, खूपच चांगला paper आहे, and you will love to, read it. Yeah.
Sure.
So that is so next, in the meantime, when the Gauri is there, Rupali, please carry forward the okay program.
Rupali, you're mute.
Yeah, so can you see this paper that I'm sharing?
Yes, ma'am.
Dakho. Yeah. So this is reducing post-Caesarean sepsis, current best practices prevention. It's a FIGO paper. It's an internet. You share it with everyone, all the faculties, because it's difficult to read.
Yes,
What is the conclusion? You can read it. And you can see the authors here. All the authors are from FIGO. And you can see nicely the name of Gauri, Karandikar, myself, and all the, committee heads and all of the FIGO. Yeah.
Okay, ma'am. Thank you.
Oh, okay. And thank you for displaying. Tell next.
So, ma'am, they have to go to amwiindia.com and or contact any of the office bearers. We will share the forms with you.
It become today to tomorrow only itself. Okay.
Yes.
Thank you all the faculties for all your valuable time today and the amazing take-home messages which we have got. I'm sure the delegates have really benefited today's talks and the videos shared by Dr. Archana ma'am and all the speakers. The scientific sessions were very good, different topics covered so crisply, very difficult as Dr. Virkud rightly said that covering this much in 15 minutes is impossible. And especially when you're a good teacher, you really feel like giving your and spread knowledge. So we'll definitely keep this in mind in the following webinars when we have. So we take leave, and before taking a leave, Swastika from Clarinet, can we just ask if there are any few queries from the delegates, maybe 2 or 3, which we can take?
And a vote of thanks, Gauri.
Yeah.
Yes, I think there are no queries. Maybe
Yeah.
So, Dr. Anjan, can you take over?
Yeah, please. We have overshot the time, but nobody is complaining because it was amazing. We were also engaged.
Very interesting.
Very interesting. And it wouldn't have been possible without the organizers. Mandakini ma'am, thank you so much. Anjali Kanhere ma'am. Mandakini ma'am, Archana Basir ma'am, and Gauri ma'am, in fact, personally supervised everything and guided us through. And we had such great speakers. We can't thank enough for their insights. And all the chairpersons, thank you so much for chairing the sessions today. And Rupali, thank you to you because you have always helped me in difficult situations. And last but not the least, Clarinet for arranging everything for us. Ma'am, a word or two from Gauri ma'am or Mandakini.
Gauri.
Yes. Thank you so much, everyone. Actually, all the Madhya Pradesh, all of you, all my friends and colleagues from Madhya Pradesh and from all over India, because we have AMWI members joining also from other states. So it has been a nice collaboration. Thank you so much, Anjum and Rupali and all of you.
We will
sorry,
like to, Gauri.
we have been coordinating with you, and they have so thanks for all the efforts that you have put in.
Gauri, sorry to interrupt. We are inviting them for our Central Asia Regional Conference.
Yes, ma'am, I was coming to that.
Yeah. Oh, sorry. I thought you are forgetting.
We did call up Dr. Bhaskar Pal and Dr. Suvarna, but actually this is Foxy MCM meeting going on, so they could not join us just now. But I'm sure it must have been difficult for them to leave that meeting. So that is one thing. And one very important announcement that we would like to make is that we are having the Central Asia Regional Congress in Mumbai on the 5th and 6th of December.
5th and 6th, yeah.
5th and 6th of December this year.
Please join.
Yeah, and please join us because we will have international faculty coming down talking specifically for medical women and women empowerment. There is also one more wing, that is the Young MWI wing that has come up, which is for women doctors who are less than 40. Okay, now this young women MWI is something which we are expanding this year, and for all postgraduates, anybody who's MBBS and above can become a member. Young MWI members get to represent India in different forum all over the world as well. Recently, they've also not from our country, but other country representatives have represented in the UN as well. Okay, so this is MWI has all its collaborations with WHO, UNFPA, UNICEF, all the international bodies, United Women.
Gauri, for a minute, I want to say something. It's a pleasure also, Gauri, for me and Dr. Vandana Vaivekar, who is our Central Asia Vice President, and I happen to be the President-elect. We both are invited by WHO. So we are representing the World Forum of Medical Women International to be present for the WHO Health Assembly, which is a very prestigious meeting, and we are just leaving on 18th and coming back on 23rd. and we will be speaking on Asian, the women's problem and medical this thing, like NCDs and so many of the Asian things we are going to medical related topics we are going to discuss. Also the violence against women and as Gauri has said, the menstrual hygiene and environmental factors. So many WHO theme we are going to talk. So I think our organization is the only organization which is officially affiliated with WHO. We got a letter from WHO. Every 3 years, the affiliation is, renewed. United Nations women, we are represented. So you all become a member, I think, and with me spreading knowledge about the AMWI, everybody is now curious and interested. So I think you all on this platform by tomorrow you should be member. Many of them are already member. Gauri, you please continue now.
Yes,
Okay.
and no, I think we will close. Thank you so much. Anything about AMWI, welcome. We are there to help. And madam, we must give Virkud sir honorary membership.
Yes, sir.
Our end, because he will help us. Because when he gives us the presentations, all our presentations will be fantastic in the World Congress.
Correct.
So,
Sir, we will like
have
to
to
take
give
your
him
help.
that.
Yeah, we will like to take his help for all our
Sure,
world
sure.
presentations, sir.
Dr.
Yes,
Megh,
thank you so much.
when you
And
do
thank you
WHO
for being with
presentation,
us.
when you do WHO presentation, I'll be happy to do the slides for you.
Yeah, sir.
Yeah,
Yes,
there was
sir.
a time when I used to do slides for all the students. I remember.
Correct.
Gauri.
I'm
So,
one of them.
Yeah.
Vandana Bhavekar, myself, you please do help us in
Yeah.
that making
Yeah,
them.
I'll do your presentation slides.
Yes, sir.
Don't
Thank you,
worry.
sir.
You give me the
Okay.
material, I'll do it.
Yeah. Thank you, sir. Thank you.
Thank you so much. Thank
Thank
you.
you
Thank
all
you,
the
all of you. Good
candidates
night.
who have joined us today. Two take-home
Thank
messages.
you, everyone.
To avoid
Thank
unnecessary
you.
cesarean. And second, like Virkud sir said, we should make use of technology to make better presentations. Thank you all.
Okay.
Have a
Bye
nice
bye.
Okay.
Thank you,
Bye-bye.
Dr.
Good night. Thank you so much.
Good night.
Good night.
Good.
Good night. Bye bye.
Thank you so much to all the dignitaries present here. Clarity is really glad to have all these brilliant people to the session today, and I really hope that you all had a seamless experience. So, with everyone's permission, we are now conclude the session in here for today, and looking forward to host you again. Thank you so much. Good night.